So thank you very much, Larry. I appreciate the opportunity to give my fifth presentation. We're going to be talking about evidence-based medical prognostication. And I'm going to do that in the context of how at Sharp we created one of the premier community-based palliative medicine programs. So the title of this is, of course, as you can see, Prognostication Made Easy Sometimes. I have plenty of disclosures. I'm a paid consultant for multiple groups. So we created a program over 13 years ago, going on 14 years, and we conceptualized this almost 16 years ago, about how to better manage patients out of the community instead of using the hospital for their care. And as you can see, over the course of this journey, we've won multiple awards because of our ingenuity. And what I'm going to tell you right now is that it's the professional skill of prognostication and moving aggressive care from the hospital to upstream that helped us to gain this level of recognition. Some of the most important things I can tell you is that in California, SB 1004 is the Medicaid palliative medicine legislation for the state of California, and much of that was based on the work that we did at Sharp. We also just recently won the Jefferson Hearst Population Management Award, and we won the Joint Commission Certificate of Distinction for the work we are doing in community-based palliative medicine. So as you've seen before, we put palliative medicine in all areas of the advanced elderly. At this time, we're looking at that light blue bar. That's where most palliative medicine was practiced. In fact, 90% of palliative care programs were inpatient when they started. We started in the outpatient arena, and only 10%, very few, are in that space. We talked about upstream palliative medicine using anticipatory guidance and developing those professional skills to guide our patients in better decision-making with hospitalizations and perhaps with surgical evaluations, knowing the unintended consequences. Now we're using palliative skills and prognostication to anticipate decompensation for patients as their illness progresses over time. So what makes the community-based palliative medicine program so unique at Sharp? And the biggest issue is that we do not wait for our patients to be hospitalized, and we are absolutely not piggybacking off of home health. In fact, we would never want our patients to be hospitalized when you can anticipate what's coming for them. And therefore, we're hoping that our patients will never see the inside of the hospital and they never participate in the revolving door of hospitalization. And I did that for many decades in my career. You'd have a very ill patient in front of you. You knew you'd done everything you were supposed to for them. You knew the specialist had done everything you were supposed to for them. But because they did not have a Medicare Part A skilled need, they ended up using the hospital for decompensation care before they could make it back to you. And what we did is we filled in that failed gap that in healthcare by giving these patients an opportunity to participate in care at home instead of running off to the hospital. And therefore, unlike many programs that you see, these patients don't need to be homebound. They absolutely do not need to have a Medicare Part A skilled need. They do not have to have been hospitalized, even though we would take them out of the hospital. What they do need to be is at that point in their journey through their chronic illness that they will start to use the hospital as a tool to manage decompensation care. In that regard, we don't consider it a success to prevent a readmission. We consider it a success to have prevented a primary admission and to continue to prevent primary admissions as we move forward. And I would say in modern day standards, one of the things to think about moving forward is the healthcare economics behind this, because I think we're letting economics define our ethics, which is the acute care model of disease. Once you're broken, we'll fix you. The new model lets ethics define economics and say, you know, we'll get paid well for managing patients so proactively that they never see the inside of the hospital until their demise, or if they ever do at all. I remind people that Hippocrates and Hippocratic physicians advised us that the professional skill of prognostication was the most professional, valuable skill that a person could have, a provider could have. And I've read this to you before, so I'm not going to repeat it, but I'm going to go a little bit more detail about prognostication. One of the questions asked 35 years ago was, why has there been such little research in individual prognosis in the terminal period? And I think that's a great question. The explanation at the time, or at least one explanation, was that doctors unconsciously need the uncertainty to justify the care they're providing to the individual patient. Now, I'm not going to sit here and say that that's necessarily the case, or then, or even now. But what I do believe is that providers now have convinced themselves that they cannot prognosticate. And if you're one of those people who says, I can't do it, it's just too hard, it's not going to happen, then you're never going to be able to move to this level of proactive management. And we're going to give you some skills today, but I encourage you, even when this presentation is over, you're not going to learn everything you need to know about prognostication, but start to grow your skills so that you can manage your patients better. One of the problems, of course, is that we stopped teaching evidence-based medical prognostication. This was an article published by Nicholas Christakis, and it looked at the number of pages in medical textbooks dedicated to the professional skill of evidence-based medical prognostication. And if you look at the second bar from the right, you can see that over a 100-year period going to the 1990s, late 1980s, we absolutely stopped teaching medical prognostication to providers. What do we focus on? We focused on diagnosis and treatment. And yes, it's of course important to know what disease the patient has and the multiple new therapies that we have. But if you look at a doctor from present day to 100 years ago, look how unbalanced those bars are. And we need to regain some of those professional skills that we've devalued over time because we've been focusing on diagnosis and treatment. So what we're encouraging people to think every single time you see an elderly patient in your practice, not only diagnosis and treatment, but what's the patient's prognosis? So now think diagnosis, treatment, and prognosis. Where are they in the progression of that patient's illness, the inevitable progress of that patient's illness over time? Of course, you have to ask the question, why do we want to prognosticate? And one of the reasons is we want to be absolutely sure that the treatment path is consistent with the goals of care of the patient. You saw that when I was talking about prognosticating risk for surgery or hospitalization. We want to move from the outdated model of reactive care to proactive care. If you can anticipate what's coming, you can have better decisions. And patients and families can participate in those decisions, not in the chaos of the emergency room of the hospital, but they can do that in the privacy of their own homes. When the patient has capacity, you can bring the family members on board because the mother or father or loved one will be able to say, no, this is what I want, and you can follow those patients with better care. And also important as good stewards of healthcare, it's far more cost effective, but we're going to show you that when we show you the results of our program. So this was a study with 343 physicians. It asked them to prognosticate on 468 of their terminally ill patients, and what we were looking at is to see how good physicians were at prognosticating about mortality for patients. What you can see is that only 20% of the time were physicians accurate. 80% of the time they were inaccurate. And what's particularly interesting is that 63% of the time they were markedly overly optimistic. 2/3 of the time they were off by 530%. And as a practicing hospice physician, we would see this all the time. The patient would be referred to hospice. They had been informed that hospice is a 6-month benefit, but in reality, they only had a few weeks to go, and that's unfortunate. They actually were told they had 6 months, but they died 2 to 3 weeks later. And I remind you that the median length of stay on hospice in this country is about 17 to 22 days. So we looked at who might be better prognosticators. Men or women didn't matter. Board certification did not matter. Being an optimistic physician about your skill set did not matter. Number of referrals to hospice in the prior year, so somebody who'd been practicing understanding how to do these referrals didn't matter. And number of medically similar patients, so if you were a specialist, it did not matter. In fact, some of the data showed that specialists might be a little bit worse than primary care physicians. And the only specialty that fell out of the pattern was oncology, which tended to be all over the place. There was a negative correlation with accurate prognostication the longer the patient and doctor had a relationship. And that's interesting because most providers would say, well, I don't know this patient, how can I prognosticate? And in fact, you may be in a better position to prognosticate because you don't have a personal relationship with that patient. To me, the fact that the doctor-patient relationship is so powerful in worsening our prognostic skills is simply a testimony to physician humanity, that we actually care about our patients. But our professional responsibility is to step back and to look at the data and look at the information to be able to relay reliable information to the patient and the family about what's going on. And that takes some time and effort to learn how to do that. I had to learn how to do that. Of course, the longer it's been since the patient has seen you, you're going to be a worse prognosticator for that patient. There was a positive correlation with experience. I'm glad to hear that. I'm in the last quarter of my professional career. Patients who had been with new providers didn't get quite as accurate a prognostic effort as long-term providers, but that particular data set's important to know. Of course, the only group that's more overly optimistic than healthcare providers are patients and families. And what you can see is reality exists in one place and medical evidence exists somewhere else. When I used to work as an expert witness, the problem wasn't that physicians didn't get it right, that the patient was going to die at some point, but the expectations from the patient and family were in a completely different place. And so we have to align those two issues so that patients and families can understand where they're at in the bell curve of life and make better decisions. There's one more piece to this puzzle, is how well do we actually represent ourselves? And there's a little bit of an older article, 2001, looking at oncologists. I'm not trying to pick on oncologists, but it's representative. There's other articles that show the same information. And in this particular research article, the researchers went to the oncologists and they said, just tell me how you represent information to your patients. 37% said, well, I give them a frank opinion of what I think their survival is going to be. 40% said, I'm not going to tell them the exact truth. I'm either going to under or overestimate. 23% refused to respond. That's very interesting. So only a third of the time can we say that if you go to a physician, an oncologist in this research article, are they even going to give you a frank estimate? So not only do we have 2/3 of our physicians being overly optimistic, only 1/3 of our physicians are going to give us a frank estimate. And that's why we end up with such chaos when it comes to prognosticating from the patients and families' perspectives. So here's a basic tool about prognostication. Number one, there are 3 types of prognostication. You should use them all. Time prognostication looks at how long until the event will occur. Event prognostication asks what's the next event in the expected series of events. A, B, C, D, E, F, G, 1, 2, 3, 4, 5, 6, 7, what's the next event? Probability, how likely is that event to occur? So the question, of course, then is how good is our training of those types of prognostication? And usually when people are asked about prognostication, they're thinking about time prognostication. And in fact, we are not mostly very good at time prognostication unless you have high-end training through hospice or palliative medicine. Now, those can be learned and we can get better. Event prognostication, we should be very good at and we should use it. What's the next event in the expected series of events? New York Heart Association, 1, 2, 3, 4. MELD scoring, as it gets higher, you know what that means. That's for cirrhosis of the liver. BODE scoring for lung disease. FAST scoring for dementia. It tells you what's coming next in the expected series of events. Now, probability of an event occurring is also something we're very good at. There's lots of research giving statistics, but we need to use those when we're talking to our patients. And in fact, when we prognosticate, we should be using all 3 of these the best we can to guide our treatment options and discuss outcomes and decisions with our patients and their families. So I would say that the reason doctors consider themselves poor prognosticators is because we lack the training and perseverate about time prognostication. Remember to think about event and probability prognostication and work to develop your skills in time prognostication. So let's talk about prognosticating using a specific program. And you can adapt this to anything you do in healthcare, but I'm going to show you how we develop the community-based palliative care program transitions. And the first thing you have to ask when you refer a patient to this program, or thinking about that as a primary care physician or specialist, we get many referrals from specialists, is what is the main diagnosis? Because most of our patients have multiple diagnoses. What's the one that's leading the race to take that patient to the end of their life? And is it actually in late stage? The farther you are out from end of life, the harder it is to prognosticate. And it gets much easier as time goes by, and you can see what's happening with the patient. They're getting closer to the end of life. The other question you have to ask is, has the patient had maximum medical therapy? And this is, in fact, Medicare's criteria for maximum medical therapy. Number one, there's truly no other treatment to provide. And that's a traditional pathway treatment, not alternative treatments. And there's almost always something that we can do. You can always give another round of chemotherapy, not that it's beneficial, and frankly, in many cases, it's actually harmful. And many people don't qualify for an LVAD or other treatments that may be available. But under those circumstances, you would have to say that those patients have nothing more that we can do. The other maximum medical therapy is patients are intolerant to further care. So if a patient has congestive heart failure, they're on all the appropriate blood tests, there's no further treatments, their blood pressure is 90/60, it's hard to give them more Lasix because yes, they won't die of heart failure, but they will die of hypotension and dehydration. The patient can refuse further treatment, and that's probably one of the most common choices that we see because they can understand that the consequences of treatment or inappropriate treatments are not in their best interest. And the patient is either so non-compliant with their care or non-compliant with treatments that they're repeatedly hospitalized. That would be a Medicare criteria. So when you've gotten to that point in the inevitable consequences of the progression of the patient's chronic illness, COPD, congestive heart failure, cirrhosis, renal disease, dementia, the next thing you have to do is to use your professional tools to prognosticate. And the more tools you use, the better. If one of the tools is an outlier to your prognostic events, you have to reconcile why that is, or you have to reevaluate your presumption that the patient's actually late stage. So I would say that the more tools you use, the better off you will be. And what are those tools? Well, number one, you want to start off with general prognostic information. Older patients, male for unclear reasons, have worse prognosis with most diagnoses. BMI matters, so particularly low BMIs or high BMIs. Most issues in the elderly are a J-shaped curve, so if you get particularly low, it's a straight line up, and if it's a rising BMI, it's a slow but gradual increase. Unintended weight loss can prognosticate general information. Depression, as we already talked about, frailty and other geriatric syndromes can prognosticate information for you. When you add biometric models to general information, functional decline patterns, disease-specific, non-specific biologic data, and you adjust for your personal tendencies, I've adjusted for my tendencies of being an overly optimistic physician. You can actually provide effective, accurate, professional, and compassionate information to your patients and families. So here's some examples of biometric models. In fact, there's dozens, if not hundreds of biometric models, so I didn't want to list them all. It's heart failure, pulmonary disease, liver disease, cancer, dementia. Those are some of the common models that we see, but other models such as Medicare's LCDs for hospice, that's the criteria for which patients will qualify for hospice. That would be an event prognostication model, because you can look at the criteria and say, yes, you will qualify for the event of getting these additional benefits. But there's many examples of what a patient would qualify for and prognostic models that can help you in your decision making. There's 4 basic functional decline patterns. These are sudden death, end organ disease, cancer, and debility, which includes frailty and dementia. And those patterns, as you can see, is sudden drop-off. Cancer is becoming a little bit less of a sudden drop-off. It's actually becoming more like a chronic illness or organ failure. So you can think of it a little bit more like that these days. Organ failure has these dips, and eventually after each dip, you decline a little bit more until you finally reach demise and frailty or dementia on the bottom of a starting low and staying low and going over a long period of time. I will show you something about functional decline patterns that's particularly important. This article was published in 2001. We looked at ADL decline in the trajectories of disease over time, and we looked at diseases such as COPD, congestive heart failure, and we compared those to cancer. And cancer historically has had a rapid decline, which is easy for patients to use their eyes to see what's going on, and that's what they use to prognosticate. But physicians need to be using more than that. And it's hard to see the decline in COPD and heart failure. In fact, if you look at this, the ADL decline between 12 months and 6 months, only a little bit for cancer, but it's almost non-existent for end organ disease. So if you're looking at functional decline to help you decide what the next step is or where the patient is in the trajectory of their illness, you're going to miss the opportunity to find the patient 6 months out. In fact, you're probably going to find the patient 6 weeks out, maybe even 2 or 3 weeks out. I remind people that the median length of stay on hospice in this country is about 18 to 22 days. That is far less than for which the benefit exists. And if we start to do better than just looking at the ability to function, but all the other tools that are available, we can do a better job in anticipating care. So the pearls from this, when we look at this, is that 6 months prior to death, these patients are still ambulatory, they are alert and oriented, and they're not in pain. And that is not traditionally what we think of as a hospice patient, but in fact, these patients would qualify for hospice if you know what you're looking for. I would also point out, as I said before, is that functional decline is not a whole lot different at 12 months than it is at 6 months. So we need to be looking much further upstream and looking at other issues to anticipate the inevitable consequences of the progression of their illness. I would show you something that you can do with anticipating care with ADL deficiency. This was a study that occurred over several years, over 6,000 patients, and they followed these patients, and every 6 months or so, they would call these patients and ask about functional decline. And what they found was that they called severe disability with 3 or more ADL deficiencies. Catastrophic severe disability is when they went from 0 ADL deficiencies to 3 ADL deficiencies, and gradual severe ADL deficiency was when they went to 1 or 2 to 3, and what they were prognosticating for was the probability of hospitalization. And in the year for which severe disability occurs, if it's catastrophic, that patient has a 72% chance of being hospitalized. If it's gradual severe disability, 1 or 2 going to 3, there's almost a 50%, 48.6% chance of being hospitalized. And if it's, if you look at those patients that just have some disability, these would be controlled, 22%. And if they had no disability, it was only 14%. So is that a piece of information that you would use to anticipate needs for your patients if you saw them develop another ADL deficiency? And the fact is, you can use they're having difficulty bathing, difficulty dressing, grooming, toileting, transferring, feeding, walking across a room to anticipate their need to use the hospital. You can look at biologic data. And of course, we know to look at the absolute level, but we also look at progression of markers, because both of those can guide you in the care that you need to find where the patient's moving to. When you look at time prognostication, one of the things we encourage people to stay away from is saying things we've heard in the past. Maybe some people still use these, but saying, I'd be surprised if you were here in 6 months. That is not a good way to express time prognostication. A better way to express that is to say, if I had 100 people in your situation, this is what medical evidence says the bell curve would look like. Other providers and palliative providers say this is the worst case scenario and this is the best case scenario. But using something to give people a description, knowing that if you have 100 people, this is what the distribution looks like. Because there's no single point that you can determine for one individual patient. And frankly, we've all had that difficult situation where the patient came back and said, well, the doctor said I was going to be dead in 6 months and they're still here 2 years later, or vice versa, where my father died in 2 weeks and they said he'd be here in 6 months. Event prognostication, again, is prognostication which guides the patient in the expected series of events. And in fact, I would suggest that we have all had this experience. In fact, parts of healthcare, if you didn't use event prognostication, you would be kicked out of healthcare. You have to do this. And what is that area of healthcare? It's called anticipatory guidance for children. Most people who practice in pediatrics realize that there's markers that we look at as children age to make sure that they're developing properly. But the other part of anticipatory guidance is to recognize that there are harms that come as patients age. So we want to be sure we're protecting them, such as getting the chemicals out of harm's way, or anything the patient can put in their mouth, the child can put in their mouth once they start crawling. So we lock everything up. We put all those dangerous chemicals up on the shelves. The other thing that we do, and I did for years, I did hundreds of deliveries in my residency, is we remind patients, parents, at 1 day, 1 week, 1 month, 2 months, 4 months, that you do not bathe that child in any more than 2 inches of tepid water. And I personally don't care if we don't have cell phones back then, the phone's ringing in the other room, something's burning on the stove, or somebody's knocking at the door. You make that child safe, and then you can go do whatever it is that you wish to do. So the question, of course, is that when you retire as a family physician who's taking care of children, or a pediatrician, what's the number of drownings? Because that's what we're trying to do by preventing drownings and you only using 2 inches of tepid water. What's the number of drownings that we consider acceptable? What are we shooting for? And the answer, of course, is 0. We know what's coming and we know how to prevent it. That's anticipatory guidance. Well, isn't it interesting then that in the adult population, on the other side of the bell curve, for a problem such as heart failure, when we know what's coming and we know how to prevent it, what's the number of drownings for a patient due to heart failure that we consider acceptable? And unfortunately, the answer isn't 0. I'm going to show you how using anticipatory guidance and event prognostication, we were able to markedly decrease the number of patients having congestive heart failure exacerbations prior to their demise. And it is not by a little bit. It is by simply changing the construct for which we approach the management of our patients. There's tools you can use at the other side of that bell curve. This is the Communitybased performance scale. Other people have heard of the Palliative performance scale. There are disease-specific models, as you can see with FAST and those other biometric models I showed. But these are just general prognostic models we use in palliative and hospice care. People should get to know these because this shows the expression of the patient's disease on their ability to function, and it does give you some guidance in what's happening with the patient as their disease progresses. So let's take these tools and let's walk through a real case. This is a patient that I inherited. This is now, my gosh, it's 14 years ago. I actually inherited him about 15, 16 years ago. He was 82 years old at the time. He'd had a couple of stents due to coronary artery disease. And he comes into my office one day with some shortness of breath. And so I made the diagnosis that he had congestive heart failure, which we did an echocardiogram and confirmed the diagnosis in appropriate testing. So how do you prognosticate for this gentleman? Well, he's 82 years old, he's older, and he's male. He had normal BMI, he wasn't depressed, so his general information was fine. He didn't have any geriatric syndromes at that time. Congestive heart failure, what's the prognostic model, biometric model you can use? Is using the New York Heart Association. The ACC also has a developmental model. But in the New York Heart Association, patients in stage 3 have about 5 years. And when they get to stage 4, it's about a 30 to 50% mortality at 1 year. So we have the biometric model. But there's other things you can look at as well. You can look at disease-specific and non-specific biometric markers. So you can see his BNP getting worse over time, even though we're giving him more medicines. And in fact, you can use medications as a tool to prognosticate. So if you inherit a patient who's already on the appropriate medications, beta blockers, ACE inhibitors, or ARBs, spironolactone. We were using DIG and hydralazine in the past a lot more, but if they get to the point where they're on diuretics, that's particularly telling that they're farther in the process. So you can use those medications to prognosticate. You use the general information. You use the biometric markers. And one of the problems, of course, is if you're not communicating with your patient, every time that patient comes to see you and you tune them up, they think they're as healthy as they are the first time they met you regarding their heart failure, but you know that they're progressing over time. So when you see a patient with heart failure, you should put down the time that they were initially diagnosed with stage 3 heart failure, because that does not last forever. You can also use the functional decline patterns. Oops, excuse me. And I want to tell you what happened with this patient, because I have been following this patient. I knew what was going on. And somewhere between March of 2010 and December of 2010, the patient came in to see me for urinary incontinence. By that time, he was on all the proper blood pressure medications for his heart failure and furosemide. But he only came in for incontinence. He already had 2 ADL deficiencies. So using the model I gave you before, knowing that he's already about 4 or 5 years into his heart failure, looking at the progression of his BNP, saying his heart is straining for, this man went from 2 to 3 ADL deficiencies, and his probability of being admitted to the hospital that year were about 50%. I looked at other biometric markers, and you can see that at this time, due to intravascular volume depletion, he was starting to have an elevation in his BUN and creatinine. And if you look at work from Thomas Hayward and others for cardiologists, by the time that BUN gets to about 55 or 60 and the creatinine gets to about 2.5, they have about 6 months to go. You can look at non-specific data such as his hemoglobin. Over time, that will drop. That has to do with the inflammatory expression of disease over time. But let's go back to December 10th. What happens December 10th if you don't anticipate it? What event starts to happen? And that's the point in the inevitable consequences of the natural progression of this gentleman's congestive heart failure, for which he saw the cardiologist and said, there's nothing more we can do, that he will start to use the hospital for decompensation care. Historically, that's the acute care model of disease. Wait till you're broken, we'll fix you. We created a program so I could put him on the transitions program and manage his disease and compensations in his home as soon as they started. We call that, in fact, at Sharp, the transitions point, because that's when patients move on to the transitions program and we keep them from ever seeing the inside of the hospital non-electively. Now, these patients still see their primary care physicians. It's a dual program. They still see their specialists. We just manage them so effectively that they don't start the revolving door of hospitalization. Hospitalization's home, home health, hospitalization, nursing home, home health, home, and that event cycle is terminated. In fact, we know from research that patients in the last year of life will see the inside of the hospital about 3.5 times, and we have virtually eliminated that. And I can tell you as a physician, since we started this program, for patients who qualify for the program, I do not remember the last time one of my patients was admitted to the hospital for a heart failure exacerbation, and you can quote me. Now, I'm not going to go over this slide again because I did this in a different presentation, but you can do the exact same thing for frailty or dementia. The same information, that same pattern, general information, biometric models, disease-specific, non-specific markers. In this case, I added on social decline because it also helped to prognosticate. We knew what was coming for this patient, which is why I put them on hospice, and then the pressure ulcers, then the pneumonia, then the delirium occurred, because that's the inevitable consequences of the natural progression of illness. You don't have to wait for the patient to be hospitalized for those events to occur, and you have the time to discuss and deal with the existential suffering of the patient and the family much more proactively than putting them through an unfortunate event. So we took all of this skill set and information. We worked with our hospice program to move that care upstream. We worked with our medical groups, And these are two research articles you can pull to see what we did. The first one was published in 2013, and the next one was published in about 2016. This is the research which defined all the awards which we received, and I want to show you the results. So when patients are on our program, usual care in the hospital compared to care on our community-based palliative program plummeted. And you can see how huge those deltas are. Those are PMs, per member per month costs. And for cancer, they're on for about 5 months. And for all other diagnoses, they're on for somewhere between 7 and 8 months. You can multiply that difference and see how much hospital costs we save for these patients. A lot of people said, well, you're probably spending more in the outpatient arena. In fact, they're managed so much more effectively in virtually every diagnosis. They're not overutilizing medicines. They're being taught how to use their medicines appropriately. They're taught about the disease process, so they're more effective in their utilization. The families are reconciled in care, and we are available for them 24/7, so we can intervene before a catastrophic event occurs where they need to use the hospital or to use the emergency room. I'd like to point out for dementia, this was original research. We actually showed that you could control the cost of dementia by proactive management. So there's the total cost savings per healthcare per month. And you can take any diagnosis, COPD, that's about 7 times $4,400. And imagine how much money you would save in your medical group and keep your patients from having unnecessary COPD exacerbations with intubations and hospitalizations. This is one of my favorite slides because for years I lived in the world where patients were always admitted to the hospital prior to their demise. And what this shows is that most patients in healthcare don't need to follow that pathway. I do not believe it's our patient's responsibility to get sick so we can finance ourselves or show them how good we are at managing disease. I would simply rather use Hippocratic prognostic skills and guide these patients upstream to keep them from needing the hospital in the first place. And 90% of our patients say that's what they want. They want to live and die in their own homes. Not all, but most of them. So to me, this is the most important slide I can show you from the work that we've done in creating proactive medical management with our community-based program using professional prognostic skills. Also important, and the reason I included this slide is that we have very few deaths in the hospital. But I'm including this slide, we have many others, but I'm including this one because most people look at the silo for which a problem exists and they try to fix it in the silo. If you want to fix hospital deaths, you have to look 1, 2, 3 silos upstream from before the patient hits the hospital. And in many silos, you have to do the same thing. So for those of you who are in systems trying to treat the problems with your hospital inpatient mortality rate, time to look upstream, use your prognostic skills, learn about some of the things we talked about with geriatric syndromes, and you'll be able to dramatically lower your deaths in the hospital and provide better care for your patients. These are total costs. If you put everything together, you can see where most of those costs occur, but that benefit extends out to about 6 months, and then it just stays stable prior to that. This is a comparison to other research. In fact, it's not exactly the same, so it's not in perfect comparison. Richard Bromley did work out of Kaiser. He should be acknowledged for starting a program such as this, but the unique program that we created is patients don't need home health, they don't need a Medicare Part A skilled need, they don't need to be hospitalized, they don't need to be homebound. They simply need to be at risk of starting to use the hospital as a tool to manage decompensation care. I would show you that most of these patients, they transfer to hospice by their request. They get more services. They're comfortable with in-home care. They're not afraid to move forward. And except for cancer, which we've improved recently, these patients are on service for at least 200, even 250% of what the normal median length of stay would be for patients on hospice. And we know the medical research shows that patients' families are more satisfied when patients are on hospice for a longer period of time so that they can deal with their existential suffering issues. These are patients and participants' perspectives, usually the families. Most of the patients can't participate in the questions. This is a Likert scale, so we only accept 5s. You can see the lowest score is 74. If we include a 4 or 5, the lowest score is 94, and most of these go to 100%. So I want to say thank you. That's a discussion of prognostication in the context of a community-based palliative program. There's many programs that people can use, but the concepts behind prognostication are there, and they can be transferred and used to help you in managing your patients. So thank you very much, and I hope you have a nice day.